Hello there, I'm Dr. Saras. Today I'll be giving you a short lecture on the introduction to orthodontic removable appliances. A removable appliance is an orthodontic appliance that can be inserted into and removed out of the mouth as desired. This will be favorable to the patients because it allows them to remove the appliance and clean it conveniently outside the mouth. It will also allow the clinicians to adjust and activate the appliance extraorally. The removable appliance can be active or passive. A passive removable appliance does not exert force on the teeth for any active movement. Hence, it will not contain any active component. A retainer and a space maintainer are examples of passive removable appliance. On the other hand, an active removable appliance is used to generate some movement on the teeth. The appliance requires regular activation to allow favorable movement of the teeth. The outline of the lecture will include the components of an appliance, materials and instruments, mode of action, advantages, disadvantages, and limitations. So let's get started with the components of a removable appliance. A removable appliance generally consists of 4 components with the acronym ARA, which are the active component, retaining component, anchorage, and base plate. The active component in a removable appliance is responsible to move the teeth as required. It is used to apply force to the particular teeth in the desired direction to allow the tooth movement to take place. It includes springs, screws, bows, and elastics. Springs are usually made from 0.5, 0.6, or 0.7 millimeter diameter stainless steel wire. Springs such as Z-spring, T-spring, and finger spring are commonly fabricated using a 0.5 or 0.6 millimeter wire. In contrary, buccal canine retractors are usually made from 0.7 millimeter diameter stainless steel wire. Screws are used to move groups of teeth, such as in the correction of posterior crossbite or single tooth in anterior crossbite. A total amount of 0.25 millimeter is achieved with 1/4 turn, which is equivalent to a single turn of the screw. The screw must be turned in the direction of the arrow marked on the appliance to ensure an ideal activation. Depending on each case and the space requirement, the screw can be turned every 3 to 7 days using an activation pin. As an active component, bows are commonly used to reduce the overjet. Robert's retractor is an example of an active bow. On the other hand, the labial bow on a Hawley retainer can be an active component to assist in reducing the overjet, although at most times, the Hawley retainer is used as a retention appliance after active orthodontic appliance. Elastics are sometimes used with some modification on the removable appliance. It can be used to retract the upper labial segment, but it is difficult to be controlled. Moving on to the retaining component. These are parts of the removable appliance that are incorporated to ensure the appliance stays firmly in the patient's mouth. Patient will feel comfortable and will have the courage to wear the appliance as required only if it fits well. If it's loose or ill-fitting, it may put off the patient and they may not wear it as necessary. As a result, they may lack the confidence to wear the appliance during their normal daily activities. Therefore, the appliance should retain well in the mouth comfortably to gain good patient compliance. Adams clasp labial bow South end clasp and ball-ended clasp are a few examples of retaining components. The selection depends on the stage of eruption of the teeth that is going to be retained or clasped and the movement that is desired. The third component is the anchorage. Anchorage is defined as the resistance to forces created by the active components to prevent undesired tooth movement. Orthodontic force is applied to move the teeth, and the reaction to this force can produce a movement of the other teeth in the opposite direction. Hence, anchorage control means maximizing the wanted tooth movements and minimizing the unwanted tooth movements. Anchorage can be extraoral or intraoral. Extraoral can be provided by a headgear which is used in conjunction with a removable appliance. Intraoral anchorage, on the other hand, can be intramaxillary or intermaxillary. Intramaxillary is within the same arch, which can be provided by the clasp or labial bow, whereas intermaxillary is between the upper and lower arch. This is usually when one arch is treated with a removable appliance while the opposing arch is being treated with fixed appliance, whereby one arch provides anchorage for the movement in the other arch. The anchorage provided will depend on the type of tooth movement and the surface area of the tooth. With the removable appliance, it is difficult to prevent tipping of the anchorage teeth, but it can be controlled with adequate adaptation of the clasp and bows. The final component of an appliance is the base plate. The base plate connects all the components of the appliance together. The acrylic base plate can be fabricated using self-cure or heat-cure acrylic. The acrylic can be added on the base plate to act as an anterior or posterior bite plane for cases that require opening of the bite or eliminating a possible occlusal interference respectively. The base plate can also be extended over the occlusal surface of teeth to serve as buccal capping. It can facilitate the eruption of opposing teeth, whereby the contact between opposing teeth are released, allowing the eruption of the trapped teeth. Crossbites can be corrected using a posterior bite plane, while a deep bite can be reduced using an anterior bite plane in growing individuals. Now let's talk about the materials and instruments commonly used with regards to removable appliance. Stainless steel is used for the fabrication of most of the metallic components of an appliance. The most commonly used variety is the 18-8 stainless steel alloy containing 18% of chromium and 8% of nickel. Wire gauges of 0.6 mm and above are of medium hardness. It has the adequate hardness and strength to bend. However, it cannot be overworked during the fabrication or adjustment. Wires of 0.6 and 0.7 mm are usually used for clasps and self-supporting springs. The thinner wires of 0.5 mm are used for finger springs and Z-springs. Wire bending pliers such as Adams Universal Plier are most useful for adjustments. Spring-forming pliers also help in wire bending during the fabrication or adjustment. The plier tips are usually used to adjust light wires and springs. When thicker wires require adjustment, the wire should be grasped nearer to the hinge to avoid damage to the plier. Wire cutting pliers, such as the Mohn cutting plier, can be used to cut stainless steel wire that can be used to fabricate any kind of springs. Other instruments includes the stainless steel spring dividers and metal ruler. These two instruments can be used to measure distance between teeth. The mode of action of a removable appliance includes tipping, intrusion, rotation, and controlled apical movements. This appliance works by applying controlled force to the crown of the teeth. It applies a single point contact force to the crown of the tooth, hence only tipping movements occur. The fulcrum around a point located 1/3 from the root apex, which is called the center of resistance. Force application around 25 to 50 grams can tip a tooth with the crown moving around 1 millimeter per month. Intrusion occurs via relative intrusion of groups of teeth, which can be achieved by contact with an appliance fitted in the opposing arch. When a bite plane is incorporated, an intrusive force is generated on the teeth that contacts the bite plane. The amount of true intrusion is small, and the overbite reduction is mainly due to eruption of the posterior teeth. The rotational movement requires a two-point contact on the crown of the teeth. It needs a well-positioned force couple on the tooth, and it needs to be controlled. It usually is carried out in conjunction with a fixed component. Well, why do we use removable appliances? There are several advantages. Firstly, the appliance is fabricated in the laboratory in advance of the appointment. So during the appointment, only fitting and adjustment will be done. Therefore, the chairside time is reduced. The removable appliance can be removed as desired by the patient and reinserted as soon as possible. Hence, this appliance is removable. However, patient must remember to wear it more often than not wearing in order to achieve the treatment objective. The palatal anchorage in a removable appliance gives good stability. This allows more favorable tooth movement. The bigger area of acrylic coverage increases the anchorage. Removable appliance is a simple appliance. It is easy to fit and adjust. It can be prescribed by most clinicians, and it does not require extreme specialized knowledge. By using a removable appliance, all components are connected by a base plate. It is more efficient to move blocks of teeth as compared to fixed appliances, as it is able to transmit forces to blocks of teeth faster. However, there are several disadvantages associated with removable appliances. It is heavily dependent on the patient's cooperation to wear the appliance as instructed when they are away from the clinic. The outcome of treatment depends on the patient's compliance. Therefore, there will only be results if the appliance is worn as required. It is also difficult to carry out complex tooth movements. Correction of teeth that requires bodily tooth movement or severe derotation is difficult. So the possibilities of treatment are somewhat limited with the removable appliance. At the initial stage of wearing the appliance, there will be increased saliva production as a normal body response, and the speech may also be affected initially. This may cause discomfort and demotivate the patient to wear the appliance. However, these disadvantages are only temporary. The lower appliance is difficult to tolerate due to the tongue mainly, which easily dislodges the appliance. So this requires adequate retention components and well-planned design. Removable appliance fabrication can be optimized with good skills of the technician. This is to ensure absolute perfect extension and fit to give maximum comfort, which is vital to increase the trust of the patient. Coming to the final segment of this lecture, the limitations of a removable appliance. This can be divided generally into three factors: the clinician factor, patient factor, and the malocclusion factor. Starting off with the clinician factor, experience and preference plays a vital role. Some clinicians are very experienced and well versed with the technique of using removable appliance. They are very versatile in designing and carrying out orthodontic mechanics using both the removable and fixed orthodontic appliance. However, some clinicians prefer to treat their patients with fixed appliances entirely. This is due to other factors such as the duration of treatment, cost of appliance, and patient load. Using the appliance consecutively increases the duration of treatment and the cost of both will be higher. Moreover, when a practice has got a high patient load, clinicians prefer to use fixed appliance to be able to complete more cases, as they are in control entirely and do not depend on patient compliance to wear the appliance. Experienced technicians are needed to be able to fabricate a good removable appliance that fits and works well. A good laboratory support is essential to provide good quality appliance for a successful outcome. Secondly, coming to the patient factor. It is crucial that a patient wears the appliance diligently as advised, as compliance to wear ensures positive treatment outcome. The improvement in malocclusion will only occur if there are sufficient hours of wear. Otherwise, there will not be much improvement. Motivated patients are important to ensure continuous teamwork between the clinician and the patient throughout, as the treatment duration with a removable appliance may take between 9 and 12 months. Patients must also be financially capable to pay for the removable and fixed appliances if the treatment involves a two-phase method. Otherwise, a single-phase treatment would be cheaper. As of the malocclusion factor, removable appliance mainly works through tipping movements. Therefore, if a malocclusion requires more complex movements, a removable appliance may not be feasible. If more teeth need to be bodily moved, fixed appliance will be more suitable compared to removable appliance in terms of cost, orthodontic mechanics, and the total treatment duration. So as a conclusion, we should examine and diagnose a patient well and choose the most appropriate design of an appliance. An appropriate and accurate design should be taken into consideration depending on the type of tooth movement and the complexity of the malocclusion. This will give you a good positive outcome and makes the clinician as well as the patient happy. So choose wisely for a successful outcome. This is an extra read for your own knowledge. So that's all for me for this lecture. Thank you and have a good day.